Human consciousness operates in what appear to be absolute binaries. We are either globally awake, with neural networks fully illuminated, or entirely asleep. Normal deep sleep relies on this global synchronization. The brain's electrical activity slows to a unified rhythm, allowing for systemic recovery. Sexsomnia, or sleep-related sexual behavior, challenges this binary by presenting a unique neurological paradox. Clinically, this condition functions as a mechanical failure in sleep architecture, a breakdown of the biological boundaries that normally keep sleep and wakefulness distinct. It is classified as a non-REM parasomnia, sharing the same underlying biological pathways as sleepwalking and confusional arousals. This occurs through a mixed state of arousal. While the brain as a whole remains in a deep sleep rhythm, activation becomes localized. The motor cortex boots up and draws power, while the prefrontal cortex, the center for conscious awareness, remains suppressed. In this state, the brain is capable of executing local motor functions while the global self remains offline. Understanding how the brain initiates involuntary action requires mapping the timeline of a standard sleep cycle. Clinicians use a hypnogram to track these transitions, plotting a patient's exact neurological state across the night. The brain descends through a strict progression, moving from the light sleep of N1 and N2 into a deep, sustained trough known as N3. N3 is the deepest stage of non-REM sleep. It is defined by slow wave activity, where the high-frequency firing of wakefulness is replaced by slow, heavy delta waves. This stage provides essential structural restoration. To protect this process, biology enforces the total suppression of conscious awareness. This slow wave state is distinct from REM sleep, which occurs at a different point in the cycle and involves high brain activity and vivid dreaming. Because N3 is the most unconscious layer of the sleep architecture, it serves as the bedrock for structural failures like sleepwalking, sleep terrors, and sexsomnia. The failure occurs in a specific fraction of a second within that N3 trough. It begins with an arousal attempt. An internal or external stimulus prompts the brain to rapidly ascend from N3 toward waking consciousness. This is an incomplete transition. The signal gets stuck. The brain has abandoned the total paralysis of deep sleep, but it has not reached the threshold for full wakefulness. Suspended between these two boundaries, the neural architecture fractures into the dissociated state. One consequence is that motor systems power on. This enables physical movement, sexual vocalization, and complex tactile actions. Simultaneously, the prefrontal cortex fails to activate. Conscious decision-making and awareness remain entirely suppressed. Finally, the memory and coding networks remain dormant. The brain does not record the event as it happens. In this moment, the body is operating on a biological autopilot, driven by basal drives without any higher-level oversight. The resulting behavior is a purely mechanical, localized motor response, entirely divorced from human intent, cognitive control, or memory. To an observer, this internal mechanical error can look deceptively like intentional behavior. Bed partners often report episodes of complex sexual behavior that appear goal-directed but exhibit an automatic, robotic quality. Because the memory centers were suppressed, the patient has total amnesia for the event. If they are forcibly awakened, they experience intense, disorienting confusion. Clinical diagnosis requires isolating this specific N3 dissociation from a wider range of nocturnal phenomena. This diagram compares REM sleep behavior disorder with N3 parasomnias. In REM, seen on the left, the brain is highly active, but the limbs are immobilized. In sexsomnia, on the right, the brain is mostly dormant while the motor systems are active. A patient with a REM disorder is physically acting out a vivid dream because their motor paralysis failed. A sexsomnia patient is not dreaming at all. They are experiencing an incomplete arousal from N3. Diagnosis also involves ruling out nocturnal seizures. Sexsomnia lacks the distinct epileptic electrical signatures usually seen on an EEG during a seizure. Definitive diagnosis relies on neurophysiologically proving which sleep stage the behavior originates in, rather than interpreting the external behavior itself. Why does the N3 architecture break down and trigger these incomplete arousals? The primary cause is sleep fragmentation. fragmentation shatters the continuity of deep sleep. Instead of a stable trough, the brain experiences dozens of sharp microarousals throughout the night. Obstructive sleep apnea is one of the most common physical causes of this fragmentation. When breathing is interrupted, the brain is forced to attempt an arousal to survive. Over hundreds of these events per night, the probability of the brain getting stuck in a dissociated state increases significantly. Environmental and chemical factors also play a role. Severe stress, irregular schedules, and the use of alcohol or sedatives all degrade the stability of the sleep cycle. Sexsomnia is usually a downstream mechanical symptom of a destabilized and structurally fragmented sleep architecture. Clinical intervention focuses on resolving the underlying instability of the sleep cycle. The treatment directive is to restabilize the M3 baseline architecture. Treating comorbidities like sleep apnea with CPAP therapy often eliminates the fragmented arousals and the resulting parasomnia. In resistant cases, medications like benzodiazepines or SSRIs are used to neurologically enforce sleep stability. During treatment, safety measures, including trigger control and separate sleeping arrangements, are necessary to prevent harm. Untreated sexsomnia carries heavy stakes, including emotional distress, relationship strain, and serious legal implications. Because this is an automatic physiological response occurring without consciousness, true sexual consent cannot be established or given during an episode. As shown here, definitive diagnosis through video polysomnography is essential. It provides the neurophysiological evidence needed for targeted treatment and legal clarity. These cases reveal that the brain is capable of executing complex physical routines completely isolated from the conscious self. Sleep is a complex, fragile architecture where highly localized mechanical failures produce profound human actions entirely outside of human intent.